Welcome to the latest series of the podcast Medical Evidence Matters with me, Liz Tucker, the podcast aimed at doctors and patients. In this week's episode, I'm talking to Dr. Kevin J. Tracey about the extraordinary impact the vagus nerve, which connects every organ in the body to the brain, can have on our health. Kevin has been a pioneer in the development and use of bioelectronic devices to stimulate this nerve to treat a range of autoimmune illnesses. And he's the author of a new book, The Great Nerve, The New Science of the Vagus Nerve and How to Harness Its Healing Reflexes, published by Penguin Life. Patient trials have shown that remarkably, we can electrically stimulate the vagus nerve to ameliorate the symptoms of conditions such as rheumatoid arthritis and multiple sclerosis. While Kevin is clear, the treatment won't work for everyone. For some patients, the results have been truly remarkable, enabling them to walk unaided again for the first time in decades and get back a quality of life they had thought was gone forever. And for all of us, it now appears that lifestyle interventions such as cold showers, meditation, and how we breathe may offer critically important strategies to effectively regulating our vagus nerve and so maximise its impact on our health. But before we get to Kevin's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com/whatyourgpdoesn'ttell or via PayPal on my website, whatyourgpdoesn'ttellyou.com. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. And now back to Kevin's interview. Dr. Kevin J. Tracey is President, CEO, and the Karcher's Family Distinguished Chair in Medical Research at the Feinstein Institutes for Medical Research. In addition, he is also Professor of Molecular Medicine and Neurosurgery at the Donald and Barbara Zucker School of Medicine and Executive Vice President of Research at Northwell Health. Kevin is a leader in the fields of inflammation and vagus nerve stimulation. In addition, he holds more than 120 US patents for devices he's invented. Here's his interview. Well, Kevin, thank you so much for joining the podcast today.
Thank you for having me on. It's great to be here.
So, Kevin, I think a good place to start. What exactly is the vagus nerve and what does it do?
The vagus nerve, we talk of it in the singular, but you actually have two of them, like two thumbs and two kidneys, one on each side. And it travels from about the level of your ear, originating in the base of your brainstem, and travels down your neck on both sides, across your chest on both sides, and down into the abdomen. And along the way, it sends branches, connections to essentially all the organs that you don't think about all day long. But the signals it carries are like a transatlantic cable. It's carrying signals back and forth between your body and your brain. And the information in those signals is absolutely critical to the reflexes that keep all your organs functioning and in balance and in harmony, so that all day long, this reflexive information is traveling back and forth in the vagus nerve. And that information is keeping your organs functioning in what we call homeostasis or balance without you thinking about it all day long.
So it's interacting very, very closely with our autonomic nervous system.
It's a fundamental member of the autonomic nervous system. So we should probably explain that just a little bit. So when you think about writing a letter or playing the piano or hitting a golf ball, those actions are under your voluntary control. And the voluntary nervous system connects the signals between your brain, your spinal cord, and your muscles, your arms and legs. The involuntary nervous system is the autonomic nervous system. Those signals travel primarily in the vagus nerve and what's called the sympathetic nerves. The sympathetic nerves coordinate the visible responses you see during fight or flight, And the signals in the vagus nerve carry the signals that we classically associate with rest and digest.
We often think of these as the sympathetic and the parasympathetic.
Correct. So the sympathetic nervous system and the parasympathetic nervous system are classically defined as acting in opposition. But as I explain in a lot of detail in the book, that's actually an oversimplification. For instance, during exercise, the signals traveling from your brain to your heart in the sympathetic nerves tend to speed your heart up and increase the force of your contractility, your cardiac contractility, and raise your blood pressure. And those are all things that you can visibly notice when you're exercising. However, what you can't notice is that during exercise, signals are also traveling in the parasympathetic vagus nerves. Those signals to your heart tend to slow down the heartbeat a little bit. And the question is, why would the nervous system push and pull at the same time, which is what it's doing? And the answer is that's how you get fine-tuned control in all of physiology. So when insulin is released, which lowers glucose, for example, there's a counter-regulatory signal to release glucagon, which at the same time tends to raise glucose levels a little bit. Back to the fight or flight example versus rest and digest, the sympathetic and parasympathetic, they actually act in harmony in many instances. So during exercise, if you experimentally stop the signals traveling in the vagus nerve, you actually decrease the performance of the heart. You decrease cardiac output. You decrease the blood flowing through the coronary arteries. So it's a little more complicated than one pushes against the other. That's not how biology works. There's much more synergy and harmony than there is battling.
Now, your particular interest in the vagus nerve was how you could harness its benefits and whether that might have implications for a range of diseases which have inflammation at their core.
Yeah, for the past going on 30 years now, my colleagues and I have been pursuing a very surprising discovery we made in my laboratory at the Feinstein Institutes in New York. And what we discovered is that the vagus nerve carries signals that can turn off inflammation. This came about because we were studying the effects of a drug that we were using in animals that had a stroke, that had infarction, brain infarctions. The idea we had was that if we stopped inflammation in the brain with these anti-inflammatory molecules, that the stroke would be smaller. And it was. What we didn't expect is that when we looked in the body of those animals, in the organs like the spleen and the liver, we found that inflammation was being turned off in the body when we put the anti-inflammatory drug in the brain. So we had discovered that signals travel from the brain to the body to specifically turn off inflammation. And in the past 25 years, we've mapped the origin of those signals into the neurons that send their fibers from the brain down the vagus nerve. And knowing that, it's been possible for us to develop nerve stimulators that we can attach to the vagus nerve in humans with rheumatoid arthritis. And in fact, in many of those patients, significantly reduce their inflammation. Some of those patients to the point where they no longer need to take medications for their rheumatoid arthritis.
Inflammatory disease, I think, is a phrase which gets thrown around a lot. When something is an inflammatory condition, what does it actually do to our bodies?
Again, let's agree on some basic terms. The origin of inflammation goes back to the origin of animals. So inflammation has been a property of animals throughout evolution. What does that tell us? That tells us it's very important. Inflammation is a very good thing in the overwhelming majority of cases. Inflammation fights off infection. Inflammation accelerates wound healing. So inflammation is the redness, the heat, the pain, and the swelling that you see after an infected wound or after you sprain your ankle or have other injuries. So that response to injury and infection is normally beneficial. The problem with inflammation comes when it doesn't stop. It doesn't stop after some short-lived period of time. Now becomes a problem rather than a a benefit. So you asked specifically, what kind of problems does inflammation cause? It causes autoimmune diseases like rheumatoid arthritis, inflammatory bowel disease, multiple sclerosis. These conditions are all characterized by sort of unchecked inflammation, where now the inflammation is actually damaging the kidneys or the joints or the brain or other tissues. Inflammation actually can cause cancer. Too much inflammation in the wrong tissues can cause the growth of cancer cells. Not all cancers, but some cancers are quite likely, if not caused by inflammation, made significantly worse by it. So, for instance, some breast cancers and some cancers of the pancreas. Inflammation contributes to Alzheimer's disease, neurodegeneration. It contributes to the insulin resistance that you see in metabolic syndrome and in patients with type 2 diabetes. It's a ubiquitous underlying mechanism that, if unrestrained and uncontrolled, causes problems. And the immune system is regulated by the brain. And that's one of the major signals that restrains inflammation in the vast majority of people. When you have a healthy vagus nerve access to your immune system, you are less likely to have severe damaging inflammation.
Now, one of the things that can happen in a lot of inflammatory disease is that the patients can suffer from something called a cytokine storm, chemicals that are supposed to promote healing, but at too high a level can cause problems. And your work actually discovered how one of these cytokines could actually have its production reduced by the vagus nerve.
Exactly right. If you recall, during COVID, there was a great deal of talk about cytokine storm. And what that referred to were those patients that came in and suddenly became very, very ill with severe inflammation and inflammatory damage in their lungs, in their heart, characterized by low blood pressure. Cytokines are molecules made by white blood cells, by your immune system. And what you could think of them as hormones or messengers about inflammation and other immune responses. So one white blood cell may produce a cytokine that can activate the next white blood cell over, or all the surrounding white blood cells, to begin producing many, many more cytokines. Those cytokines, some of them can turn on the action of other white blood cells, and some of those cytokines can turn the action of those white blood cells off. So cytokine storm refers to the massive release of these signals to inflammation, to the point where the inflammation can be so serious that it damages the host, damages the patient.
The first patient to really try the use of a medical device harnessing the vagus nerve was a woman who had Crohn's disease and inflammatory arthritis. Can you explain what impact the stimulator had on her?
Kelly Owens was one of the first patients, one of the patients in one of the first trials. What's important about her story is that she had been sharing her story most of her life on social media, blogs, Facebook, and other social media posts. And Kelly was and is a strong advocate for the importance of pursuing new therapies for the condition she had, which was Crohn's disease. So Crohn's disease is a condition of excessive inflammation in the bowel, but the inflammation is not restricted to the bowel. It can affect other tissues. And in Kelly's case, she developed severe arthritis in combination with severe inflammation in her intestines. She, as a young woman, was a teacher, and ultimately, because of repeated hospitalizations and because of repeated bouts of severe illness, she was in and out of a wheelchair. Her father gave her a cane for one of her birthdays. And this all culminated in the fact that her doctors told her, well, we've tried all the options that we can think of to treat you, and you should probably retire from teaching and go home and plan a life with your husband, but with no children, because it's just too risky to have children with this kind of condition. Kelly resisted this recommendation and talked herself into a clinical trial of a vagus nerve stimulation company that I started called Set Point Medical. And she and her husband, Sean, sold their earthly belongings and moved with the support of friends and family and neighbors, moved to the Netherlands for 6 months, where she participated in a clinical trial in Amsterdam, where surgeons implanted a vagus nerve stimulator that Set Point was testing to prove the idea that we had discovered in my lab, that stimulating the vagus nerve could stop the inflammation in Kelly's case. And Kelly had a simply remarkable response to this therapy. Within 2 weeks, she felt significantly better. Within 6 weeks, she had stopped taking all of her other medications that she'd been taking for many years. And within several months, she was able to wean herself off of the last medication, which was steroids. Those have to be tapered off very slowly over a long period of time. Kelly came to see me and gave me a present. She gave me her cane that she no longer needed. And it's sitting proudly in the corner of my office, where if I'm having a bad day, I turn and look at it, and it reminds me of why my colleagues and I do what we do. We're trying to invent things in the lab based on science that we can pursue in the hopes of helping people.
And why was the trial happening in the Netherlands and not in the US?
There were several reasons for that. The first reason was the ability of European physicians to embrace new ideas and enroll patients into the trials. We had done not a formal analysis, but a friendly analysis of calling colleagues at the major medical centers. I had convened actually a meeting in my office of a number of what they call KOLs, or key opinion leaders in rheumatoid arthritis at that time. And they worked diligently with my colleagues and I at Set Point and at the Feinstein Institute. We designed a clinical trial. And when the time came to launch the clinical trial, I called them all back and said, we're going to get going. Start think about what patients you want to put in this trial. And they said, I'm not putting any patients in that trial. And I said, you helped us design the trial. You had yes, but I have to follow my clinical guidelines and my practice. And in Europe, the European physicians, in this case, primarily in Amsterdam, but later also in Stockholm and in Bosnia and in Croatia, the European physicians either were not satisfied with the current medical therapies, as are actually, as you know, many of the patients also not satisfied with the current therapies, or they said, I may be satisfied with the therapies, but my patients want to try something new, which is another way of saying somebody's not satisfied with the therapy. So that's why we went to Europe first. It was much more feasible to do it there. Now, those primary study results have been replicated in the United States in a large trial. Kelly's trial was on the order of 20 patients or something. The major study findings have all been completely replicated in the United States. The data was read out last year at the American College of Rheumatology, and from 242 patients with severe rheumatoid arthritis. What do I mean by severe? I mean, they're still having signs and symptoms of rheumatoid arthritis despite having taken powerful immunosuppressive drugs called biologics. All of the patients in the trial had tried multiple therapies, biologics and or JAKs or JAK inhibitors. These patients were having persisting symptoms, and many patients actually wanted to have a vagus nerve stimulator implanted rather than continue to pursue additional drug options. The trial hit its primary endpoints. Prior to it even being completed, it was designated by the FDA as a breakthrough product. And as you and I are speaking now, any day now, we're awaiting the FDA's final decision, which I hope and expect will be positive, that will lead to the use of this idea in patients with rheumatoid arthritis in the United States first. And obviously, once the regulatory approvals and paperwork have been filed elsewhere, I suspect that other countries will follow the lead, but that remains to be seen.
So how long have your earliest patients now been using one of these stimulators?
Oh, a long time. The very first patient was implanted in Mostar, Bosnia back in the early 20 teens. So around 2011 or 2012, I believe it was.
Because I guess one of the issues is this just dampening down the symptoms and stopping the current inflammation, or actually altering the course of the disease? Because obviously one thing that people with arthritis will suffer from is over time, their bones will gradually become deformed due to the inflammatory process. So are you able to see one of these stimulators actually changes the course of the disease, not just the symptoms?
That's an incredibly important question that's an area of active and ongoing study. Now, obviously, if someone has had damage in their cartilage and bones from rheumatoid arthritis for 30 years or 20 years, that's not going to be undone once the bones have totally reset.
Sure.
The real question is, if you stop or reduce the inflammation in the patients before that damage is permanent and sets in, can you see healing and repair? That is the important question. The early evidence is that that may actually be possible with vagus nerve stimulation. In the trial I just referred to, that was reported out at the American College of Rheumatology last November, to a lot of fanfare, by the way. There's a tremendous interest in this. There are now results looking at MRI scans from those patients showing evidence of healing and evidence that is beneficially impacting the actual progression of the disease. Now, at the end of the day, there's a lot of questions here, right? So what causes rheumatoid arthritis? We don't know. Why does stopping inflammation stop the arthritis? Well, there's a lot of theories and hypotheses, but you can't say for certain why blocking TNF stops rheumatoid arthritis. Why does blocking IL-1, another cytokine, treat rheumatoid arthritis? There's lots of theories, and there's lots of evidence that in many patients, blocking a specific cytokine with a biologic against TNF or a biologic against IL-1, these can have miraculous effects in many patients, but not all. Why not all? We don't know. We don't know why blocking TNF with one biologic in one patient does not work, but blocking TNF in the same patient with another biologic might work. So there's a lot of questions about what causes rheumatoid arthritis. And what we do know is that in treating patients with vagus nerve stimulation, it can be done safely without immunosuppression. And we know this because at least 250,000 patients, that's what the numbers that are available in the literature, but I estimate it's more than 1 million patients.
Is that worldwide, that figure?
Worldwide, more than 1 million patients have been treated with a vagus nerve stimulator because they have epilepsy or depression. Those indications were approved by the US and the European FDA decades ago. So what do we know about the safety of vagus nerve stimulation from those patients? We know they do not develop immunosuppression. The risk of surgery is less than 1%, especially with experienced surgeons. And the risks of surgery are things like a wound infection that can happen with any surgery. The risk of damaging the nerve is possible, but it's very small. The commonest risk is that when the device is actually buzzing or firing, if the patient is speaking at the time, there's a risk that their voice will vibrate or develop a vibrato. But in the case of the set point device, it only fires for 1 minute a day. So that risk is completely minimized. So now what is the question? The question is, would patients prefer to have injectable drugs like biologics that are immunosuppressive and have black box warnings, which is the most serious side effect warning from the FDA, which work half the time and in the US cost $100,000 a year in many instances? Or do they want to have a vagus nerve implant that's the size of a vitamin tablet implanted in their left neck in the hopes that they would have a clinical response, which isn't guaranteed, of course, but they would have a clinical response and not have to take those drugs anymore? So that's the question that's going to be asked in the coming months and years now.
Well, Kevin, as I ask all my interviewees, can I ask you what your financial interest is in this and how you financially benefit from it?
In the early days, 2007, I was a co-founder of Set Point Medical and a consultant, and I was a board member. And that's the company that's now moving these clinical trials into a product launch in the US, I hope, pending the FDA decision. Over the past 18 years, as SetPoint has grown and I've seen the clinical results, I resigned from the board of SetPoint so that I could put my attention and my efforts into running my lab, not running the company. I continue to consult for SetPoint and help them whenever they ask me to. And I still have equity position in the company, although it's a lot smaller than it was when I started the company, unfortunately.
Thank you for clarifying that. So how do the costs of a device compare with somebody using medication? And obviously with medication, that would be an annual bill they would be paying.
For a specific answer to this question, I'd have to refer you to SetPoint. I don't know how the device will be priced and how it will be paid for by insurance companies and by Medicare and Medicaid in the US. Those questions are being studied now by all of the stakeholders. If it turns out to be comparable to, say, a cardiac pacemaker or a vagus nerve stimulator for epilepsy and depression, what I imagine is that there would be a one-time payment on the order of maybe $50,000 or $75,000 for the implantation in the left neck. The surgery should take about a half hour or an hour, and the patient should be able to go home the same day from the hospital, in and out on the same day. A few weeks later, maybe two, the patient will go to their doctor, the rheumatologist, if it's rheumatoid arthritis, and the physician or the caregiver will activate the device through a tablet, like an iPad, which communicates to the device and turns it on and sets the amount of current and the amount of minutes a day, which I believe to begin will be a minute a day. Then the patient will come back every month or 6 weeks, like they do now, to see their physician and get checked on their progress. And as the therapy progresses, the physician will adjust the prescriptions for the medications they take, but will also adjust on the tablet the treatment that the vagus nerve stimulator is delivering in the neck. This procedure with the current device that SetPoint is launching should be once for life. That's what we expect. The label will probably say once for 10 years because it's very difficult to do long-term testing and to know for certain, will something last for 30 years? So it'll probably have a 10-year label, but I would not be surprised if in many patients the lifespan fully exceeds that. The battery is fully rechargeable. The patient puts a collar on to recharge the battery once a week. And it's very possible that that will be their primary therapy. It won't work for everybody. Let's be very clear. No single therapy works in 100% of patients. My hope is that some cohort of patients, a third or a half, have a highly significant clinical response, and that the other patients are divided between those that have a little response, meaning that maybe they take a lower dose of their medications or fewer medications, and those patients that have no noticeable response for reasons we don't understand.
So very broadly, and obviously we haven't got the precise figures, but knowing that biologics tend to be pretty expensive, if a patient was able to come off all their medication and just use their vagus nerve stimulator, it's likely the costs for that would probably equate to something like a year's drug supply.
In the United States, it could be even more. I mean, in the United States, many patients are taking medications that cost $75,000 or $100,000 US dollars year after year after year. Some patients are forced to choose between taking their medications and declaring bankruptcy. And it's really amazing, actually, Liz, because if you think about it, these drugs have side effects. They're invasive. They have to be injected. They cause immunosuppression. Patients don't like the way it makes them feel, and they work about half the time.
Of course, if they cause immunosuppression, that's increasing patients' risk for a number of other diseases.
Other serious conditions. Now, we have to be careful, right? Because there's no doubt that these medications have been revolutionary for some patients. For some patients, the 50 or 40% that they work well in, those patients are able to resume normal lives. But in the US, that's going to be very expensive. And if a similar benefit, or maybe even a superior benefit, could be achieved with vagus nerve stimulation implanted once before the disease has progressed to severe fixed conditions, I think it's not known yet. There haven't been enough patients. We're talking about results that we understand from the laboratory, and we're talking about results from, I estimate, 300 or 350 patients so far worldwide. I can't wait to see what happens when we have the data from 10,000 patients or 100,000 patients, because I think those days are coming and we'll know. I think it's going to help a lot of people.
So what other inflammatory diseases do you see this helping?
In the short term, I think you're going to see additional clinical trials in multiple sclerosis and in inflammatory bowel disease. There are many factors at play in which conditions get studied when and how. There are regulatory factors, there are financial factors, there are healthcare provider factors. And so my understanding is that clinical trials that will be launched later this year by SetPoint will go after multiple sclerosis. In the next 5 years or 7, looking out a little further, I think you're going to see other companies coming in with their devices. And I think you're going to see clinical trials in conditions ranging from diabetes to other autoimmune conditions to Alzheimer's disease to even cancer.
A number of these conditions that you've mentioned, there's, I think, increasing interest and evidence also about the role of diet, and particularly things like, say, ketogenic diets, particularly for neurological conditions. And I wonder where that fits into this.
It fits in ways that are interesting and complicated and under very detailed study. So let's just take the case first of the GLP-1s. There's fascinating evidence that GLP-1s are interacting with the vagus nerve in the intestines and sending signals up the vagus nerve to the brain. And this is studied in great detail in mice and rats because you can do very, very sophisticated molecular and neurophysiological analysis of these pathways. The reason I start with this first is because there have been clinical studies in humans as well. Reported in The Lancet, patients were undergoing surgery for gastric cancer. And as part of that surgery, they were having their vagus nerves cut below the diaphragm, which is not uncommon for this type of gastric surgery. And so the investigators, in a fascinating study, tested their GLP-1 response before and after surgery. And what they discovered is that the normal response to GLP-1 is GLP-1 injections are followed by anorexia and a fall in blood glucose, which is why they, of course, developed early on for diabetes. Now, after the vagus nerves were cut and they repeated that injection of GLP-1s, the patients did not develop the anorexia and they did not develop the falling glucose. So what does that mean? It means the GLP-1s are acting on the vagus nerve fibers, presumably in the intestines, but we're not even exactly sure where. And the signals traveling up the vagus nerve, the sensory vagus nerve, the A for afferent vagus nerve, those arrive in the brain. The brain is processing that information, and the brain is sending signals back out, either the vagus nerve or other nerves, which contribute to the feeling of fullness, the anorexia, and actually have a role in lowering blood glucose levels. So it's complicated. When you apply the same logic to ketogenic diet, ketones activate signals in the vagus nerve that can induce a feeling of satiety. And once those signals drive up the vagus nerve into the brain, now you're talking about first millions and then billions of synapses participating in brain network responses that, frankly, we're just beginning to think about and sort out.
I mean, I was just thinking, for example, of Johns Hopkins working with children with intractable epilepsy on ketogenic diet, which has had a long history. When drugs haven't worked for these children, that's worked for them.
Absolutely true. And it's interesting, isn't it, that ketogenic diet is used to treat epilepsy. Vagus nerve stimulation is used to treat epilepsy. And do they come together? It's an interesting hypothesis. It's a testable hypothesis. The answer today is we don't know, but maybe.
One of the things I found really intriguing in your book was the potential evidence for a transcutaneous electrical nerve stimulator to stimulate the cartilage surrounding the ear. You start off the story by mentioning a colleague who appears to have used it to successfully manage his particular inflammation.
Exactly. My colleague Ulf Andersson in Sweden is a pediatric rheumatologist, retired professor at the Karolinska Institute, who had a serious inflammatory condition in his abdomen after a procedure called a Whipple procedure, which is a major abdominal procedure. And what Ulf experienced was bouts of inflammation, waves of inflammation and depression that were quite debilitating. He and I were talking about the fact that vagus nerve stimulation can suppress inflammation. And we came across the idea of using electrical stimulation to the ear as a way to stimulate a branch of the vagus nerve called the auricular branch of the vagus nerve. Now, the auricular branch is auricular as an auricle or AU auricle. It's a sensory branch. In evolutionary terms, the cartilage of fish is innervated by the fish vagus nerve. And as evolution exerted its influence from fish to primates, it dragged with it the cartilage from the gills and it turned it into the cartilage of your external ear. And it dragged with it that branch of the vagus nerve called the auricular branch. So when you place a TENS unit, an electrode, which you can buy over the counter for $30, when you place these electrical stimulators on the cartilage of your ear, you can activate the sensory branch of the vagus nerve. Is that the same as putting a vagus nerve stimulator in your neck? Absolutely not. It's completely different. But it does send signals into the vagus nerve system in your brain.
And where on the ear do you place it, Kevin?
You would place it in what's called the cymboconcha. And if you Google that, you'll see a picture. It looks like the clamshell that surrounds the opening to your ear canal. We need to advocate to all of your listeners not to put anything in their ear, but the seashell-like outer structure of your ear, the cartilage, is called the cymboconcha, and that's where the vagus nerve branch goes.
And what I thought was fascinating was, alongside 4 colleagues, you used the machine yourself. Can you explain what you did?
We purchased a TENS unit for $25 or something, and we put the probe in that area called the cymboconcha and delivered a small amount of current for 5 minutes. It doesn't hurt. It shouldn't hurt. If it hurts, you're doing something wrong. And by the way, none of your listeners should do any of this without checking with their doctor first.
Sure, we don't give medical advice on this podcast, just to be clear.
Absolutely. We're not giving medical advice. You asked me what I did, and I described it in the book. And we put these TENS units in the cymboconcha, in the cartilage around the opening to our outer ear. And we delivered this current, a few hundred microamps, pulsing in spikes at about 30 hertz. Each spike was about 200 microseconds. These spikes of current feel like a little buzzing in your ear. They feel like a little vibration on your outer ear. And then what we did is we tested using an analysis of cytokines that we talked about before, cytokines like TNF and IL-1 and IL-6. We tested the ability of our white blood cells to produce cytokines. And what we found, and we've published this in peer-reviewed journals many times actually, what we found is that the amount of cytokines produced by our own white blood cells and subsequently the white blood cells of patients and volunteers we've studied in clinical trials, the amount of cytokines that's produced is reduced by putting the TENS unit on the cymboconcha. Does that mean that will become a therapy for some condition or other? No, it doesn't. A lot more clinical study is necessary. What it does mean is that these are very interesting results that warrant additional study.
I suppose some people would point to the ancient history of acupuncture as indicating the importance of the ear in certain medical conditions. Do you think there's any connection between that and what you found?
It's very difficult, if not impossible, to prove the mechanism in humans. The signal goes in, whether it's from a TENS unit or an acupuncture needle. Let's say that somehow you knew how to do this, and I'm not sure we do. You knew how to only stimulate the auricular branch of the vagus nerve. Why is that important? Well, because there's 4 or 5 other nerves there, and everyone's a little different. Nerves have overlapping fields. Are you really stimulating the auricular branch in patient 1 versus patient 2? Or are you stimulating a branch of the occipital nerve or a branch of the trigeminal nerve or a branch of the facial nerve? Very, very hard to know exactly what you're doing from patient A to patient B to patient C. The second thing is, even if, as I said, you could prove to yourself or prove to your colleagues that you knew exactly what you were doing and you were stimulating the auricular branch, once that signal travels into the brainstem, it goes into a place that's called the nucleus tractus solitarius, which is like a router. Now, if the signal goes into a router, just like the router in your basement, the signals can come out 1,000 different ways or 1,000,000 different ways or 1,000,000,000 different ways. So how do you really know what you're doing? You really don't. One of the reasons I wrote the book was to explain that there's nothing wrong with people talking about this. There is something wrong with people selling things based on this and claiming they know all the mechanisms. And there is something wrong with talking people out of their hard-earned money without solid clinical and experimental proof. And a lot of times that's lacking. I try to tell the stories in the book of why it makes sense. And the ancient Chinese acupuncture maps of the ear were actually born by a Frenchman in 1957 who was interested in patients who had been treated with acupuncture-like therapy and cautery of the ear. But it was this Frenchman, Dr. Paul Nogier, who actually made the first maps, presented them at an acupuncture meeting in the Middle East and then later in China. And the Chinese response was overwhelming, and they adopted all of his maps. And so the ancient acupuncture maps of the ear are actually only 50 years old.
Well, one thing you do certainly tackle in the book, you're not advising us all to go out and buy a TENS machine, but you are suggesting there are some things we can do in our everyday life to maximize the potential of our vagus nerve. And one thing you mention is meditation, which I always feel I should be doing. And it's something I've always found quite hard to do.
Meditation is a word that when you try to define it or do a clinical study of it, turns out to be very, very complicated because there's very many different ways of meditating. So putting that out as a big caveat and as a second big caveat that different kinds of meditation are often associated with different kinds of breathing. Breathing affects the vagus nerve. When you breathe in, you expand your lungs. The expansion of your lungs sends signals up your sensory afferent vagus fibers. Those fibers activate reflexes in the brain, which send signals back down to the muscles of your diaphragm and the muscles of your chest and on and on and on. The muscles in your arteries, which regulate blood flow, the muscles in your heart, which regulate how much blood flows to your lungs. I mean, it gets complicated really, really quickly just when you take a breath in and a breath out. So there's almost zero accepted scientific mechanistic evidence, but it seems like an infinite amount of data on correlations between vagus nerve related functions and the brain and the state of the brain imaging, and various relaxation or meditative practices. I gave a snapshot in the book of these. If the book was only an answer to your question, it would be an encyclopedia 3 feet thick.
So perhaps tell people what you do to potentially maximize the benefit.
What I do to maximize the benefit of health benefits of my vagus nerve reflexes is I focus on the things that yours and my primary care provider tell us, and probably our grandma told us too, which is eat a balanced diet, try to get a good night's sleep, get a good rest every night, best you can, exercise with some regularity, avoid stress or have a strategy for dealing with stress and anxiety, maintaining social connectivity and engagements in your interests and in your work, and practicing some sort of relaxation, meditation, or cognitive behavioral therapy. And that can include slow paced breathing, breathe in on 3 and out on 7 for 3 to 5 minutes. It can include concentrating on your breath and observing the sensations, emotions, and thoughts that come in and out of your quote unquote mind for 10 minutes. During that time, when you find yourself wrapped up in a thought or a sensation or an emotion, watch it go away and return to paying attention to your breathing. Find it very useful for people who have not meditated before. I personally have found it terrific using the app Headspace. There are others that people really seem to enjoy, and that's been useful. What do all those things have in common? All of those conditions, when done chronically, tend to slow your heart rate, your resting heart rate. So fit athletes have slower resting heart rates. Slow, deep breathing at in on 3, out on 7. So 10 seconds, 6 breaths a minute. That slows your heart rate. Relaxing, meditating, that slows your heart rate. Being in the zone when you're reading a great book, if your heart rate slows, then you know one thing. You know the fibers in your vagus nerve, not all of them, but the ones going to your heart are working pretty well.
Now, Kevin, there's one other thing you do, and that's take cold showers.
Cold showers are complicated, but they are interesting. Yes. Not every day. I know friends and colleagues and social media influencers who take cold plunges every single day religiously. The reason for the cold shower and the reason for the cold plunges for me, is to reduce inflammation. How does that work? Well, the sudden exposure to cold in a cold plunge or a cold shower, which absolutely we're not giving medical advice, and anyone thinking about doing this should definitely check with their physician first to make sure they're not at any risk to their heart or any other health condition. But the acute exposure to cold exerts a massive fight or flight response, a massive sympathetic response. Now, chronic fight or flight, there's a lot written about this, billions of web impressions, but chronic stress is a stimulus to inflammation. It's not good for you. But this acute, massive fight or flight that occurs when you get that shock of the cold water, the shock of the cold, that actually is anti-inflammatory. That actually suppresses inflammation. There's been some really good work on this. My colleagues and I have done some of it. There's clear evidence that a massive fight or flight response suppresses inflammation. If you can do it, if you can stay in the cold, get back to a slow, controlled breathing, and you find yourself almost, me personally, almost like I'm in a meditative state. I feel like I'm watching someone else experience the cold. It doesn't get comfortable. I don't think it ever gets comfortable.
I mean, the only thing I can think of personally is going in a cold sea, and it's so cold. I'm half Irish, so we always go in the very cold sea off the west coast of Ireland. And as soon as you got in the water, your breathing was because the shock of the cold is so great.
That's fight or flight. With that massive discharge of the sympathetic nervous system, it's as if you can't breathe. You exhale the air that's in your lungs. If you stay there, I don't think it gets comfortable. Some people claim that it gets comfortable for them. I don't buy that. I think you become aware of the pain in a different way. If you can resume a normal, slow breathing, and you can do it, you can actually notice your pulse will slow. And as your pulse slows, that's evidence that you're now stimulating the parasympathetic, the vagus nerve. And that is anti-inflammatory. At least the fibers that go to the immune system are. Once again, they may not be the same fibers in the vagus nerve that are going to the heart, but it's an interesting idea. So these things, believe it or not, have not been studied in large controlled trials anywhere near as much as most people assume it has been. Almost all the trials are small groups of people studied in a cold room, studied in a cold bath, studied in a physiology laboratory. There's very, very few real world studies of this that have been subjected to good statistical analysis with appropriate control populations. So what does that mean? It means people are saying a lot of stuff online and in social media that may or may not be supported by evidence.
And it's something that's quite difficult to double blind, isn't it? Because even if you've got a control group, clearly the people going through the cold process may well benefit from some placebo effect.
Very well. But then again, if every patient's serving as their own control and you do enough patients for a long enough period of time, there are ways of dealing with the placebo effect, even for something like this. But it requires a lot of patients a lot of attention to making sure that the volunteers, the subjects, patient A and B, one's not suffering from one condition and another suffering from a different condition. And who's going to pay for this? These things cost a lot of time and money. And so the answer is there's not a profit margin at the end of this, and that changes the equation completely as well. I'm not saying it's good or bad. I'm just describing on how it works.
So finally, Kevin, given what we know about the culture of medicine is not often a fast adopter of new technology, what's your hope for the future of vagus nerve stimulation in medicine?
In the coming months, my hope is that the US FDA will approve the use of this, maybe even by the time this show airs, and that it'll be approved at first for patients with severe rheumatoid arthritis who are not gaining significant benefit from the available drugs and biologics that are out there now. I think there will be, as in any truly new medical therapy, there will be a hockey stick-shaped adoption curve. There will be early adopters and a relatively slowish uptake. But then at some point, there will be a bend in the stick. The use will accelerate. And I think that demand will be driven by the patients. When SetPoint was trying to enroll 242 patients in their clinical study, 242 patients, they had tens of thousands of applicants. Now, most of the time, physicians will tell you, oh, my patients are doing pretty well on the therapy I'm giving him or her. But when tens of thousands of patients apply for a clinical trial to have a computer chip implanted in their neck, rather than go on with trying one more drug, that tells you something. So that tells you there's a pent-up demand, probably being driven in large part by the fact that we've been doing this science. The science has been out there for 25 years. And I think patients are ready for something new. Will the healthcare world be ready? Well, it's going to take some work, right? The payers are going to have to think differently. The hospitals are going to have to think differently. The physicians and all the healthcare providers are going to have to think differently. The referral patterns will have to change because there'll be, neurosurgeons involved in addition to rheumatologists. This is just for rheumatology, for RA. Once you move this conversation into multiple sclerosis, you've got neurologists thinking differently. When you move it into inflammatory bowel disease, you have gastroenterologists and general surgeons thinking differently. So the stakes are high. There are millions and millions of patients who will someday benefit from this. That's what I believe. And because the stakes are high and because the patients want new options, I think it's inevitable. I can't wait to see what comes next. I think it's going to go faster than most people think. I think people are going to want this sooner rather than later.
Well, thank you, Kevin. Absolutely fascinating. Thank you so much for sparing the time to chat today.
Thank you so much for having me on. It's really great to be here. And I congratulate you on all you've accomplished with your podcast.
Thanks so much. Goodbye, Kevin.
Bye-bye.
Hope you enjoyed the latest episode of the podcast. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.